Hello friends, today we are going to discuss management of unanticipated difficult airway in adults. With this discussion, you will feel more confident while handling the difficult airway situation and you will be more prepared. And if you practice this, you will be more competent in your day to day practice. So let's start. So first of all, we need to understand that there are human factors in the airway management, and these include cognitive overload. So when difficult airway scenarios come, they overwhelm the clinicians with information, leading to tunnel vision and delayed decisions. The mitigation strategies include checklist formation, cognitive aids, and defined team roles. We have to rely on teamwork and communication because effective airway management requires clear communication. Closed loop communication is necessary because that ensures that the instructions are properly understood. Whenever we give some instruction to somebody, the person who follows that instruction has to give feedback that this task has been done, and this is how the loop of communication is closed. Briefings and debriefings at the before and after the procedures, they also improve team awareness, and if there is any conflicts, we should address that constructively. Simulation training is also very important. If you can get access to any simulators, or even if you don't have simulators, you can just create scenarios and practice with your team, and this offers a safe space to develop technical and non-technical skills. Teams can practice crisis management, including task delegation and communication. And there is no patient risk because it is a simulated situation. This builds confidence for real emergencies. Now, when you assess airway and you plan, these are the points that we should follow. So, first of all, perform a thorough airway assessment if possible. In critical care patients, sometimes you know the patients from before and intubation situation may arise later. So always perform a thorough assessment. Identify potential difficulties with face mask ventilation or supraglottic airway device insertion, like a small mouth or limited mouth opening, or any obstruction or large tongue, or whatever that could be. And any potential difficulties for tracheal intubation and front of neck access. We will discuss about these things in a bit details in the coming slide. Now, second is to develop a strategy for airway management before induction of anesthesia and discuss it with the team, whoever is present, so they are all aware about the strategy and the plan about intubating that patient. And ultimately, we have to assess the risk of aspiration, and we have to take steps to minimize gastric volume and acidity. So if possible, aspirate your Riles tube. If possible, go for rapid sequence intubation. What is rapid sequence induction and intubation? So we know we give neuromuscular blocking agent to facilitate the face mask ventilation and intubation, but we don't give positive pressure ventilation after giving muscle relaxant. And we apply cricoid pressure to protect the airway from vomiting and aspiration. But if we realize that the intubation is difficult, we have to let go of the cricoid pressure. Now, this is called the sniffing position. This is the optimal position for bag and mask ventilation and tracheal intubation. So here there is a extension at atlanto-occipital joint and flexion at the cervical joint. This position maximizes the likelihood of successful laryngoscopy and intubation. If the patient is obese, we should use ramped position. Now, what is plan A? The first plan is obviously mask ventilation and tracheal intubation, which is the ideal way things should have gone. Position we have discussed already. We pre-oxygenate all patients before intubation and before starting anesthesia to extend the duration of apnea without desaturation. All the nitrogen in the lungs is replaced with oxygen. The duration of pre-oxygenation is at least 3 minutes and up to 5 minutes. The limited laryngoscopy attempts should be made, and this limit is maximum 3. Fourth attempt is permissible only by a more experienced colleague. Now, if you can't manage to intubate the patient, plan B is to maintain oxygenation. So you have to insert a supraglottic airway device. If tracheal intubation fails, declare it as a failed intubation and proceed to plan B. Make the whole team aware what's going on. The emphasis of plan B is to maintain oxygenation using a supraglottic airway device. A maximum of 3 attempts of supraglottic airway device insertion are recommended. And attempts includes changing the size of the SAD. If oxygenation through supraglottic device cannot be achieved after 3 attempts, then we go for plan C. Now these are some of the examples of supraglottic airway device. So A is, you can see it's iGel, B is LMA, and C is intubating LMA or LMA Supreme. So various devices could be available in your institute, and you have to make yourself familiar with what kind of device it is and how to use it. Now plan C is to final attempt at face and mask ventilation. So face and mask ventilation, if there is adequate oxygenation, then we try and wake the patient and postpone the surgery. If this situation is in critical care, then probably this step is has got very limited use because the patient will need intubation regardless. So probably we can skip this step and go to plan D. But for anesthesia, if face and mask ventilation is adequate and oxygenation is maintained, we wake the patient. If the face mask ventilation is impossible and patient is paralyzed, then we continue attempts at oxygenation through face mask, supraglottic airway device, and nasal cannula. And at this point we have to declare cannot intubate, cannot oxygenate situation, and we have to proceed to plan D if oxygenation cannot be maintained. In case of critical care patients, plan C is generally not an option, and from plan B we have to go to plan D. Plan D is emergency front of neck access. So a cannot intubate, cannot oxygenate situation arises when attempts to manage the airway by tracheal intubation, face mask, ventilation, and supraglottic device have failed. The fastest and most reliable method of securing the airway is surgical cricothyrotomy. All the anesthetists must be trained to perform surgical airway using the scalpel technique. So we will go in a little bit more detail about this. So first we have to identify cricothyroid membrane on the neck. Then we stabilize the larynx and use our left index finger to identify the cricothyroid membrane. Then remember we are standing at the head end of the patient. So then we make a transverse stab incision through the skin and the cricothyroid membrane, and the cutting edge of the blade is facing laterally. Then we rotate the scalpel 90 degrees so that the sharp edge points caudally towards the feet. Now we slide the tip of the bougie down through this small opening, and then from the side of the scalpel blade to furthest into the trachea. We remove the scalpel and railroad a lubricated 6 mm cuffed endotracheal tube over the bougie, rotating it as it is advanced. We remove the bougie, inflate the cuff, and confirm ventilation with capnography. So you realize we are entering here at the level of cricothyroid membrane. So it is below thyroid cartilage but above cricoid. So our tube will still pass, it is above the level of tracheostomy that we do. And the tube will not pass through the larynx because larynx is located at the level of around mid-thyroid cartilage. Here we are going below thyroid cartilage. So we push the tube and we inflate the cuff and start ventilating. So this will give you some time, few minutes to hours, to get surgical airway in place. Remember, in emergency situation, surgical tracheostomy or percutaneous tracheostomy can be very dangerous, and it is generally not encouraged unless you are very well trained in that. Now these are the equipments that we use for bougie assisted cricothyrotomy. So we use a scalpel blade, we use a bougie, and we use 6 number cuffed endotracheal tube. There are some other cannula techniques as well, with narrow bore cannula, wide bore cannula over guide wire, and non-Seldinger wide bore cannula. These techniques require specific equipment which may or may not be present all the time, and this kind of scenario arises once in a year or even less frequently. So scalpel cricothyrotomy is the easiest and best technique in my opinion. Now we will discuss little bit about the role of ultrasound. So ultrasound can help identify the trachea and cricothyroid membrane during the preoperative assessment. Ultrasound can be helpful in emergency situations if immediately available and switched on. And training in ultrasound guided airway is recommended for anesthetist. So this is the ultrasound view, and you can see, so you can see in the beginning there is thyroid cartilage, then there is a green line, then there is cricoid cartilage circled with red. It looks like a bump, and then there are two small tracheal rings. They are also circled with small red circles. And with the arrow I have shown the cricothyroid membrane. And on the left side of the screen you can see the cricothyroid membrane in an anatomical location. And the right side you can see ultrasound view of the cricothyroid membrane. So during all these steps we have to continue communication, and we have to document the issues. We have to discuss difficulties we face and the implications for postoperative care at the end of procedure. We have to document the airway management plan in the medical record for future needs also. And patients with airway difficulties should be followed up by the anesthetist to document and communicate complications. Every failed intubation or emergency front of neck access and airway related unplanned admission should be reviewed and discussed. So to summarize, cannot intubate, cannot oxygenate airway management, we have to always be prepared for difficult intubation, and we have to have a clear plan. We should know the scalpel bougie tube FONA technique, and we should focus on teamwork and call for help early in a cannot intubate, cannot oxygenate event. Now we will come to a different issue. We can intubate but cannot ventilate. So this is a different challenge altogether. And here what happens is we have intubated, and later during anesthesia or ventilation we realize that patient is not able to ventilate. So this is one step beyond cannot intubate, cannot oxygenate. So if we see the continuum from ventilator to alveoli, first is ventilator, including the all the connections, the hoses, the HME filter, tracheal tube, trachea itself, bronchi, bronchioles, and alveoli at the end. So first step is to verify tracheal tube placement. You can verify using capnography, video laryngoscopy, or direct laryngoscopy. And if we cannot verify, we have to extubate and reattempt. Here we are presuming that we have put the tube in the right place. Step 2 is to disconnect the ventilator and use bag valve. So this eliminates the ventilator errors and any problems with the device itself, hoses or filters. We can manually give higher pressure and immediate feedback on patient's response. We can connect this to capnography to see if there is any CO2 waveform coming. Now step 3 is to check tracheal tube patency. So we can insert a suction catheter to identify any kinks, compression or clots. We can remove obstruction by suctioning, so we can remove mucus or blood. We can retry ventilation after trying to clear the tube, and if problem persists, we can call for additional help. The next step would be to insert a fiber optic bronchoscope, which will help us identify kinking. It will locate foreign objects and give us a vision. We can confirm tube placement by seeing the tracheal rings when we enter the ET tube. We can evaluate whether the tube cuff is blocking the outlet, which is very rare, but we can evaluate that. And we can assess whether trachea or anything outside the trachea is compressing the tube and leading to cannot ventilate situation. Step 5 is to rule out or treat bronchospasm. So it is always after ruling out the tube placement and any compression or kinking, the next step would be to see whether there is bronchospasm. It is always differential, especially in patients with risk factors or who are on medications. It could be because of anaphylaxis, where you can also notice skin rash, hypotension or tachycardia. And the treatment depends on the severity and presence of anaphylaxis, but you can use steroids or inhaled bronchodilators and inhaled steroids and other medications. At the end, we have to rule out pneumothorax. So if there is unilateral chest rise, absent of respiratory sounds on stethoscopy, and any suspected tension pneumothorax, we can further evaluate. We can use ultrasound to see whether there is lung sliding on both the sides. If there is tension pneumothorax, we can do immediate needle chest decompression followed by chest drain insertion. Seventh step is to identify and treat intrapulmonary gas exchange problems. So these are all radical problems, but we have to keep them in mind. So VQ mismatch can be a problem mainly in critically ill patients or injured patients. Ultrasound in this condition may be helpful to give you more information about ventilation, lung expansion, pleural sliding, any collapse, consolidation, pneumothorax, etc. We have to optimize ventilation by adjusting the ventilator settings, considering deepening of anesthesia, gastric decompression, and neuromuscular blockade. We have to treat circulatory failure because sometimes, because of very low blood pressure, we cannot generate EtCO2 and we think that we are not able to ventilate the patient. In the extremes of the cases, we may have to consider for ECMO, and if there is major thoracic trauma or surgery, we have to consider for emergent thoracotomy, which is another radical step. So to summarize, we have to first confirm tube placement using capnography, auscultation, or fiber optic scope. We have to address obstructions by ruling out any kinks, foreign bodies, or cuff issues. We have to consider bronchospasm and treat with bronchodilators and address potential anaphylaxis. And we have to exclude pneumothorax by seeing the rise in chest and using ultrasound. And if it is present, we have to treat it. And we have to consider some other conditions which are rare but important. So this is the end of the discussion, and I hope you like this video and you found it useful. If you feel that this is useful, please share it with your friends. Please subscribe to my channel for more such contents. Until next video, see you.